Hi, for this video I'll be talking about aplastic anemia and the causes, symptoms, and current treatments, as well as my own proposed treatments. Aplastic anemia is a disease that's characterized by damage to the red bone marrow that results in a lack of production of all three types of blood cells: red blood cells or erythrocytes, white blood cells or leukocytes, and platelets. Damage to the bone marrow is critical to this disease because it's the primary site for hematopoiesis, or the differentiation of hemopoietic stem cells into the mature form of each cell type. This semester, we're focusing on energy balance, and it's important to understand the relationship of blood and energy. Blood cells, specifically erythrocytes, bind oxygen and carry it to capillary beds where nutrient exchange occurs. Every cell in your body needs oxygen to carry out its functions. Your body cells use oxygen to break down sugar, a form of glucose, which in turn releases energy in a process called cellular respiration. A lack of red blood cells leads to a deficiency of oxygen reaching other tissues, which will have a critical impact on their energy balance. In order to understand all of the symptoms of aplastic anemia, it's important to understand the functions of each of the blood cells being affected. Red blood cells are round and disc-shaped cells that have no nucleus and whose main function is to carry nutrients, primarily including oxygen, to and from the capillaries for nutrient exchange. Since anemic patients have a lack of red blood cells, they will experience symptoms that relate to a lack of oxygen reaching their tissues, including fatigue and shortness of breath. White blood cells are the cells involved in your body's immune defense. There are 5 major types of white blood cells: neutrophils, eosinophils, basophils, monocytes, and lymphocytes. There are 3 granulocytic cells: neutrophils, eosinophils, and basophils. These all contain granules in their cells. So neutrophils are the most numerous leukocyte in the blood, and they enter tissue spaces and phagocytize infectious pathogens. They're mostly involved in infectious diseases. Eosinophils stain red because of the eosin staining and increase in response to parasitic worm infections, allergic reactions, and some autoimmune disorders. Basophils have granules containing histamine and heparin, and they increase with mild proliferative disorders and decrease with acute allergic and stress reactions. The 2 agranulocytes are monocytes and lymphocytes. Monocytes exit the blood and move into tissues where they transform into large phagocytic cells called macrophages. Lymphocytes are divided into 2 types. T lymphocytes manage immune responses, and B lymphocytes become plasma cells and produce antibodies. A loss to any of these white blood cells will result in increased infections in aplastic anemia patients. Platelets are involved in the clotting response when a blood vessel is damaged. At first, when there is vascular damage, the blood vessel constricts in order to stop blood loss. Then, exposed collagen from the breakage attracts platelets to the site of the rupture. The platelets then begin to form a plug as they all rush to the damaged site. Finally, fibrin strands are incorporated to toughen this wall and form a clot. Aplastic anemia patients who have a platelet deficiency will have trouble forming blood clots, which can lead to prolonged blood loss and can be deadly. Now I want to talk about the current treatments for aplastic anemia and the pros and cons of each. Blood transfusions can be used to provide some immediate relief for those symptoms that we discussed earlier. In this treatment, the blood of a donor with healthy and compatible blood type is injected into the vein of the patient by a small needle. The new, healthy blood is then able to perform normal bodily functions that relieve the patient from the symptoms they experience due to a lack of blood cells. While this treatment isn't a cure, it's able to provide rapid relief to a patient with relatively low risk. One disadvantage of this treatment is that if the cause of aplastic anemia is left untreated, a patient will need to receive many successive blood transfusions in order to keep the levels of each blood cell in healthy amounts. Most red blood cell transfusions only last about 120 days, the lifespan of a single red blood cell. While there's no limit on the number of blood transfusions a patient can undergo, there is a higher risk for complications when a patient undergoes multiple transfusions. The patient's immune system may also develop antibodies to the transfused blood cells, rendering them less capable of performing their natural responsibilities in the body. In order to address the underlying cause of aplastic anemia, patients may be recommended to undergo a bone marrow transplant. This treatment replaces an anemic patient's defective hematopoietic stem cells with healthy ones from a compatible donor. In this procedure, the anemic patient's bone marrow is systematically destroyed by radiation or chemotherapy. Then, healthy stem cells extracted from the donor are injected intravenously to the anemic patient's bloodstream, where they gradually travel to the bone marrow cavities and begin blood cell production. This process requires a long hospital stay and close monitoring of the patient to watch for rejection of the new stem cells. If the body rejects these new stem cells, life-threatening symptoms, including shortness of breath, joint or muscle pain, nausea, vomiting, coughing, and jaundice may occur. The risk of this stem cell rejection, referred to as graft versus host disease, depends on the source of the healthy transplanted stem cells. The survival rate of a transplantation from an antigen-matched sibling donor is 86% compared to 66% from an antigen-matched unrelated donor. For this reason, many patients without a sibling or a nuclear familial match may choose not to undergo a bone marrow transplant because of the risks associated. One way to decrease the risk of the patient receiving the blood sample, of rejecting the sample, is to take out the T cells in the donor's blood samples before inserting them into the new patient. This does reduce the chance of rejection, but it leaves the patient with less of an immune response and is therefore subjected to more infections. In order to understand the last current treatment to aplastic anemia, it's important to understand one of the subtypes of the disease. Some patients have an autoimmune disease which causes their T cells to erroneously attack their own hematopoietic stem cells, resulting in stem cell and resulting cell deficiencies. This is caused by some sort of preliminary event that stimulates a successive immune response, but researchers are unclear to what these exact events could be. There seem to be many different types of events that can stimulate this kind of immune response. For those who aplastic anemia is caused by autoimmune disorder and cannot undergo a bone marrow transplant, immunosuppressant therapy may be prescribed. Immunosuppressants, usually cyclosporine and ATG, alter or suppress immune system T cells that cause damage to the bone marrow and hematopoietic cells. After continued use of these drugs, the bone marrow is able to recover and begin production of new blood cells. A patient using immunosuppressants may experience side effects related to the suppression of their immune system, including an increased risk of infection, loss of appetite, and nausea. Therefore, this treatment is relatively effective for those whose immune system is the cause of their aplastic anemia, but it comes with a high risk of increased infections. To understand the recent developments in the treatment of aplastic anemia, I interviewed Jay Lozier, a hematologist who has worked for the National Health Institute and the Federal Drug Administration. When describing a new treatment that he has contributed to, he directed me to Dr. Danielle Townsley, the PI who is primarily responsible for the research of a new drug called eltrombopag. This drug was originally given to patients with low platelet counts because it was known to increase platelet production. However, researchers noticed that eltrombopag had an unexpected effect of increasing all three major blood cell types. The use of this drug may be implemented into the standard treatment for aplastic anemia patients in the future. While talking to Dr. Townsley, she pointed me to some of the genetic mutations that are involved in aplastic anemia. One commonality in the blood cells of patients with congenital aplastic anemia is the shortened length of telomeres in all of the blood cells. In healthy cells, telomeres protect the integrity of chromosomes and contribute to longevity of cells. Over time, telomeres shorten with each cellular division, and when these sequences reach a certain limit, the cell will die. Studies have shown that mutations in the telomerase reverse transcriptase, or TERT gene, are shown to be present in patients with congenital aplastic anemia. The TERT gene encodes information dictating the assembly of hTERT, one of the two major components of telomerase. These mutations in the TERT gene lead to a lack of expression of hTERT and subsequently decreased function of telomerase as a whole. This lack of telomerase expression over time will lead to shortened telomeres in blood cells, and result in their premature death and subsequent pancytopenia in the patient. For this reason, I'm proposing a new therapy for aplastic anemia patients that involves the genomic editing of TERT mutations in hematopoietic stem cells using CRISPR technology. In this therapy, we will screen congenital aplastic anemia patients for low TERT expression using PCR. For those with low TERT expression, we will create a short piece of RNA, or guide sequence, that binds to identify mutations in the patient's DNA. The RNA will also bind to the Cas9 enzyme, which will then excise these mutations. The excised portions of DNA will then be replaced by the wild-type sequence to foster normal TERT expression. The future for the development of treatments for aplastic anemia is looking bright, and with the combined current treatments and my proposed solution, I'm confident that patients will be able to find a treatment plan that works for them.